Hello again and welcome to another section of the endocrinology series. My name is Dr. Betty Dubey, and in this section I'll be covering diabetic complications. So far we've had a look at all these listed learning objectives here, but this part of the series is focused on reviewing macro and microvascular diabetes-related complications. So I thought I would start by this diagram that I've already used in some of the other series just to sort of introduce and remind you of the different major complications of diabetes. So we have the microvascular complications that affect either the eye, the kidneys, or the nerves, and certainly the nerves of the extremities. So in the eye, you have high blood glucose and high blood pressure can damage eye blood vessels, causing retinopathy, cataract, and glaucoma. In the kidneys, high blood pressure damages small blood vessels and excess blood glucose overworks the kidneys, resulting into nephropathy. And in the nerves, so hyperglycemia damages nerves in the peripheral nervous system. This may result in pain or numbness. Feet wounds may go undetected, get infected, and lead to gangrene. And this is one of the main complications. And I think it's been documented that diabetes complications are the second most cause of amputations, second to road car accidents. Okay, and when we move on to macrovascular, so meaning this affects the larger vessels in the brain, increased risk of stroke and cerebrovascular disease, including transient ischemic attack and cognitive impairment as a result of hyperglycemia. In the heart, high blood pressure and insulin resistance increases risk of coronary heart disease. Okay, and in the extremities, the peripheral vascular disease results from narrowing of blood vessels, increasing the risk for reduced or lack of blood flow to the legs. Feet wounds are likely to heal slowly, contributing to gangrene and other complications. Okay, so when it comes to diabetes complications, can be limited and prevented through early detection and good management of the modifiable risk factors as we listed before. So blood glucose, blood pressure, and cholesterol from an early age. Also, these have a substantial impact on the NHS, costing over 10% of the total NHS budget annually. Related to direct cost of drugs, also amplified use of health services, as well as loss of productivity and long-term support required to overcome these diabetes-related complications such as blindness, if somebody does develop retinopathy, renal failure, if they do get nephropathy, and limb loss as a result of amputation from gangrene. It does occur due to a peripheral vascular disease and neuropathy, as well as cardiac disease. They occur more in type 2 diabetes due to a delay in diagnosis. And again, as I said, they can either be macrovascular or microvascular. Okay. Similar general etiology resulting from atherosclerosis of blood vessels leading to occlusion. Okay. So this occurs depending on where the vessel is affected, either it's a minute drug vessel or the major ones. So I thought I'll just include some stats here, but the updated ones might be on the Diabetes UK website. So many people are living with diabetes so far, over 5 million at the moment, and it is estimated that every 2 minutes somebody is diagnosed with diabetes. And at least over 10,000 people in the UK have end-stage renal failure because of diabetes. Okay, and over 2,000 people have their sight seriously affected by diabetes every year. When it comes to a weekly statistics, around almost 200 amputations every week due to diabetes, over almost 700 strokes, and as well as many heart incidents and causes of heart failure. So it is estimated that around 500 people with diabetes die prematurely every week. So this is quite significant if you have a look at it overall. When it comes to the complications, comparing people with or without diabetes. So if you do have diabetes, you're 2.5 more times likely to have a heart attack, as well as heart failure, and twice as much as getting a stroke. Okay, and with those with type 1 diabetes, again, they are likely way more significantly lower than the rest of the population. Okay, and these again are the numbers here every year that have been estimated to be linked to events related to diabetes, uncontrolled diabetes, or progression of diabetes. So when it comes to the macrovascular cardiovascular disease related complications, so these are either coronary heart disease and could lead to stroke, or peripheral vascular disease, or PVD. Okay, and people with diabetes are almost 4 times higher of developing these. Most common cause of death in people with type 2 diabetes is cardiovascular disease, presenting as angina, myocardial infarction, stroke, peripheral artery disease, or heart failure. The risk of cardiovascular disease is increased further by nephropathy. Okay. Other cardiovascular risk factors can be enhanced in the presence of diabetes include smoking, so if smokers should stop smoking, and hypertension should be monitored, as well as any dyslipidemia treated. Silent myocardial infarction, the myocardial infarction that occurs with no symptoms, is also very common due to the cardiac autonomic neuropathy. So there's a malfunction in the nervous system in the heart. And we also have cerebral vascular disease, also more commonly associated with diabetes. Management of cardiovascular risk is very essential, is an essential component of diabetes care rather, and individuals' preferences and needs must be considered. NICE guidelines is available that for cardiovascular disease, and it is recommended that the statin is considered for all adults with type 1 diabetes and offered to all 40-year-olds or those who've had diabetes for more than 10 years. Okay. People with type 2 diabetes should also be offered a statin. Normally, atorvastatin 20 milligrams if they have a cardiovascular risk of 10% or more. Okay. Hypertension, again, is way more pronounced in people with type 2 diabetes and diabetes in general, and it is associated with the development of both macro and microvascular complications. Therefore, its treatment is important. It's also a feature of the metabolic syndrome that we covered in the type 2 diabetes section, and is associated with insulin resistance, very close related to renal disease in type 1 diabetes. First line antihypertensive treatment is normally an angiotensin enzyme inhibitor, and ACE, and there are some exceptions, and patients of African or Caribbean family origin should be offered an ACE plus a diuretic or a calcium channel blocker, and women who may become pregnant offered a calcium channel blocker instead, because the ACE inhibitors and the ARBs have some teratogenicity associated with them. Again, you can review the cardiovascular hypertensive modules as a refresher for this section. I thought I would include here a NICE guideline 136 just to remind everyone of the choice of antihypertensive pathways and monitoring, as well as the BP targets. And it is also included here that if a patient does have diabetes, what pathway to be followed here. I just pause the video and have a quick look at this slide. When it comes to retinopathy, it is one of the leading causes of blindness in the UK, unfortunately, and this is due to persistently high blood glucose levels that damage the network of blood vessels that supply the retina, resulting in retinopathy, which is initially symptomless in the early stages, and it's really advanced before it affects vision. So screening is essential for early detection and subsequent treatment. So 20 years from onset of diabetes, almost over 90% of type 1 diabetes patients and over 60% of type 2 will have diabetic retinopathy. Okay, so tight glycemic control is important, and it's been shown to prevent and delay the progression of retinopathy for both types of diabetes. And in type 2, also tight blood pressure control does reduce the risk. Okay, so when the retinopathy is detected early, sight may be served by laser photocoagulation, and in advanced cases, surgery may be required. We'll move on to peripheral vascular disease, also known as PVD. Over 30% with diabetes who are over 50 years of age will have it. It affects arteries of the legs and causes intermittent claudication, a cramping pain experienced on walking, and it is due to reversible muscle ischemia secondary to atherosclerosis. So the iliac vessels can be affected, causing buttock pain and erectile dysfunction in some people. And I think most of you may have come across where patients who have long-term diabetes also tend to be prescribed something for ED. So it increases cardiovascular risk. As cardiovascular risk increases, around 20% of people would also suffer from a fatal myocardial infarction within 2 years of symptom onset. So PVD is also associated with diabetic foot problems. So it's very important that it's managed appropriately, and tight glycemic control would be one way for this to be managed. When we come to peripheral neuropathy, so it's a progressive loss of function in the peripheral nerve fibers. Okay, it can lead to a wide variety of sensory, motor, and autonomic symptoms. Most common is symmetrical distal sensory type, which is particularly evident in the feet and may slowly progress to complete loss of feeling. There's also distal motor neuropathy that can lead to symptoms of impaired fine coordination in the hands and foot slapping, and painful diabetic neuropathy is another manifestation of this sensory neuropathy. Autonomic neuropathy may affect any part of the sympathetic or the parasympathetic nervous system and is also a manifestation. It does present as erectile dysfunction. Bladder dysfunction also may occur, and where there's a loss of bladder tone with a large increase in volume. And gastroparesis is another one, which causes vomiting and delayed gastric intestinal transit and variable food absorption. So there's no evidence that antiemetic therapy is effective. Some may benefit from domperidone, erythromycin, or metoclopramide. Again, this is an off-label use of erythromycin, which I've seen in practice. Quite interesting when you think of erythromycin as an antibiotic. Okay, when we go back, move on to nephropathy. So diabetic renal disease. In diabetic renal disease, the kidneys become enlarged and the GFR initially increases, and as it progresses, the GFR starts to decline, and it's estimated, but really serum creatinine used alone to estimate renal function has limitations because creatinine clearance is often used for medication review, and dose optimization may be calculated using the Cockcroft and Galt formula. A formula here I've included. Again, these days there are tools we can use to calculate the eGFR. We don't have to manually do it anymore. So the presence of nephropathy is indicated by detection of microalbuminuria. Okay, high albumin is proteinuria or macroalbuminuria and signifies more severe renal damage. And we have microalbuminuria, which is an albumin creatinine ratio, so ACR of above 3 milligrams per millimole, whereas the proteinuria is an ACR of 30 milligrams per millimole or an albumin of 200 milligrams per liter. Proteinuria progresses to end-stage renal disease and may require dialysis. Albumin in urine increases the risk of cardiovascular disease, and both microalbuminuria and proteinuria associated with end-stage renal disease. Tight control of both glycemic levels and blood pressure reduces the risk of developing nephropathy, and this can be the progress can be reduced by using ACE inhibitors on ARBs. Okay, and these are the drugs of choice. Both have proven to delay the progression to proteinuria. Okay. Next is the diabetic foot problem. So estimated around 10 people with diabetes will develop a foot ulcer during their lifetime, and these can proceed to amputations and are associated with poor mobility and mortality, with over 50% of patients dying within 5 years. The rate of lower limb amputation in people with diabetes is nearly 25 times higher compared to the rest of the population. Foot problems often develop as a result of a combination of both sensory and autonomic neuropathy, PVD, poor foot care, and hyperglycemia. So people with diabetes must be educated that their feet are particularly vulnerable, and if problems arise, to seek immediate professional advice. And this is where we always counsel people to check their feet on a daily basis. Okay. So there are three main types of foot ulcers that could occur in a diabetic foot. So there's the neuropathic, ischemic, and neuroischemic. So neuropathic ulcers occur when peripheral neuropathy causes loss of pain sensation. So can be deep but usually painless, and can cause by trauma to the foot, which is not noticed until after significant damage has occurred. Then we have the ischemic ulcers, which result from PVD and poor blood circulation, causing a reduction in available nutrients and oxygen required for healing. May be painful, usually occur in the distal ends of the toes and the sides of the feet. Most ulcers have elements of both neuropathy and ischemia and are termed neuroischemic. Diabetic foot ulcers are prone to infection and require prompt antibiotic treatment. For those of you who have worked in hospital, you may have come across diabetic foot ulcers. Okay, thought I would include the differences here, the three main types of diabetic foot ulcers and how they present. In my previous practice in hospital, I did come across some of ulcers that look similar to this. So ACT now is the acronym we use: accident, change, temperature, new pain, oozing, and wound. These all require immediate attention. Take a few moments to pause to have a look at this slide. So high risk of, in fact, so this potentially could occur very rapidly within a week, it says, according to the slide. So if high risk but intact foot on the Monday, so if they didn't check it daily, then on the Tuesday it could potentially develop into an ulcer. And because the ulcer is now open, because of reduced blood flow, damaged nerves, you get infection on Wednesday, sadly, and then potentially the gangrene can occur on the Thursday. So this is just showing how progressive it can be. Probably doesn't occur this fast, but it's just the presentation that is used to educate patients on the importance of checking their feet every single day. Okay, and here's a good resource I found from George Eliot Hospital NHS Trust, and it's the discharge criteria from the multidisciplinary diabetes foot team, okay, at the outpatient clinic. And just take a few moments, pause, and have a look at this particular infographic from a few years ago. I thought it was a good representation of what should be the assessments and the potential treatments and referral pathways for people with diabetic foot. So importantly here, diabetic foot care assessment, insole and shoes, so comfortable shoes, exercising. Again, it's telling us no smoking, good hygiene is important. Assessment is really important when with anyone with diabetes. Okay, so the alphabet strategy is what I'll cover next, and this is something that's been used to reduce the progression of these diabetic complications. So A stands for advice, so smoking cessation, physical activity, weight control. So we're aiming to at least achieve between a 5% weight loss per year. Structured education, especially self-management, beliefs, knowledge, skills involving all the carers that provide care to a patient. Regular follow-up with complete annual review is essential. So 20% of patients with early severe complications will be persistent diabetes clinic non-attenders, sadly, and also we advise them to seek Diabetes UK membership, which is free. Okay, there's also the diabetes prevention lifestyle, where it recommends a 5% weight reduction in people who are obese. Okay, the B part of the strategy is blood pressure within targets. So as you've covered in the cardiovascular module, I thought I'll just include it here, and the treatment options that should be offered and certainly be checked regularly for anyone with hypertension and diabetes. So take another moment to pause at this video. Okay. Then the C is cholesterol. Again, our recommendation is the less than 40% reduction in the non-HDL cholesterol. For secondary prevention and for primary prevention, like in type 2 diabetes, we want for anyone with a cardiovascular risk of greater than 10 should be started on atorvastatin 20 milligrams once a day. And for type 1 diabetes, same for those who are 40 years of age or who have had a duration of diabetes for more than 10 years. Again, it could be quite a young age because if they are diagnosed at an early age, okay? Or if anyone who has established nephropathy or other cardiovascular risk factors. And then we also have secondary prevention here, post-MI or post-angina or stroke. 80 milligrams will be the evidence-based dose. And then for patients with chronic kidney disease, the dosing has to be varied accordingly, and ezetimibe also can be recommended, and it's as recommended by the NICE guidelines. Again, you did cover this in the cardiovascular module. Another C is the chronic kidney disease prevention, and this can be done by strict hypertension control as well as proteinuria reduction. Okay, and a drug like losartan can be used for this one. That's an ARB. Okay, then the D part of it is diabetes control. So tight glycemic control is important, making sure the HbA1c is within target. So we aim to have less than or equal to 58 millimoles per liter. Okay, and then initial prescription for type 2 diabetes is lifestyle. So always optimal diet, optimal weight, physical activity, and then we can start metformin. And if contraindicated, you can always have a look at the other options. Okay, this is really important. Again, take a few moments to pause this video. These are all just those recommendations, but we did have that step-by-step approach that could be used based on the NICE guideline 28. Okay, that should be used here, and all the recommendations, okay, of intensification from first line, second line. So initial prescription, first line intensification, second line intensification, and also third intensification. It's important. I'll take another pause here to review this slide. And then E stands for eye screening. So it's also an effective way of managing diabetic retinopathy by a trained healthcare professional. And then most patients are put on these medications for retinopathy. F is for feet screening, foot screening. This should be done on a daily basis by the patient, but also at least once a year by the general practitioner or podiatrist, and the inspection should include these listed here. And importantly, if any ulcer is identified, should be referred to a multidisciplinary team, foot at-risk team that are available. And then after F is the G. There are guardian drugs that should be initiated in people with diabetes, and these are listed here. We have aspirin, clopidogrel if there's an aspirin intolerance. There's also ACE has been shown to reduce complications, and also ARBs. Okay, these are all important to be considered guardian drugs in that ABCD AGF strategy. Okay, I thought I would summarize here. There are 9 diabetes care here. This infographic that I really liked. So A1C to target, body mass index reduction in weight, renal function, close monitoring, and the ACR close monitoring, and try to reduce the progression to proteinuria. Blood pressure check is important. Cholesterol check, diabetes eye screening, diabetes foot check, and smoking cessation will support to improve overall cardiovascular health. Okay, again, there's a video here I've put that really summarizes what I've just discussed for you to have a look at. And again, remember, we have the microvascular complications of diabetes and the macrovascular complications of diabetes, and it's important for you to know the differences between these two. Here are some resources for you to have a look. And again, thank you so much for listening. And if you do have any questions, please post those on the Moodle forum. Thank you.